So myelofibrosis, I would say, is an evolving area of research and innovation. So there've been obviously clear changes in the management, since the first JAK2 inhibitors have been implemented. And clearly there's been improvement in patients' care and survival over the years. However, there are gaps in patient treatment, and unfortunately, Ruxolitinib could not be the solution for everybody, and it might not last forever. And so multiple other pathways have been investigated. Some of them are similar to what JAK2, to what Ruxolitinib was doing and is doing. So the JAK pathways is still one of the preferred options in terms of targeting treatment. But other pathways have also been identified, either crossing the JAK pathways or supporting the JAK pathways. So there are multiple clinical trials these days, and obviously I can speak for the UK experience, where quite often the studies are designed using as a backbone Ruxolitinib as a standard, and then addition of small molecules or additional drugs in combination with Ruxolitinib to enhance the efficacy or improve the efficacy. This is in the de novo setting, so where patients have not been exposed to drugs before, or in relapse or progressing setting. Few examples that I found quite interesting. So one is PI3 kinase pathways. So there are a few clinical trials where PI3 kinase inhibitors have been involved, have been studied. The addition of a PI3 kinase inhibitor in pre-phase 3 studies demonstrated an advantage in terms of spleen reduction and constitutional symptoms improvement. BET inhibitors have been also targeted, and some new compound, once again used in combination with Ruxolitinib rather than in alternatives of Ruxolitinib, seems to be effective in enhancing the effect of Ruxo, not just for spleen reduction and symptoms control, but for instance, improvement in anemia in these patients, with a quite interesting set of data, especially for the BET inhibitors regarding fibrosis reduction and changes in the morphology of bone marrow in patients with myelofibrosis, which are quite promising and interesting. There are new drugs that are helping, supporting some of the difficult symptoms of myelofibrosis, and in particular, one of the difficult to manage and support is anemia. So drugs such as luspatercept, for example, has been used in addition to Ruxolitinib in treating patients with myelofibrosis and transfusion-dependent anemia, where the addition of this compound might improve the transfusion requirement, and in some cases actually reverse the transfusion dependency and bring patients in a transfusion independent status, which clearly help performance status and quality of life in general. There are drugs that are replacing JAK inhibitors, approaches where rather than a more direct JAK2 inhibition, there are Pan-JAK, JAK1, JAK2, JAK3 inhibitors that have been also utilized in patients with myelofibrosis, with some interesting results in their setting. And also BCL2 inhibitors are now coming into the stage really. I'm thinking about navitoclax in particular, that has been once again utilized in combination, where inhibiting the BCL2 pathways seems to have an impact in terms of myelofibrosis response, once again, in terms of spleen reduction, in terms of improvement blood count in this patient. If those data are interesting in frontline treatment, are also equally very interesting in relapsing setting, where perhaps the outcome is even more challenging, comparing with patients that have never been treated with JAK2 inhibitors before. What we've noticed in the past few years is that without an option, patients that tend to progress through Ruxolitinib didn't have a lot of options, in terms of what you can do next. So the portfolio clinical trials they are developing these days help to tackle some of those issues. Obviously, very recently, Fedratinib has been approved in second line. So what was previously in clinical trials in the UK is now an available options, in patients that have progressed or they were intolerant to Ruxolitinib, which is obviously good news as well. So we have a quite large number of studies these days where, again, the principle is very similar. So it's the addition of a new drug, rather than replacement of the original Ruxolitinib. But it's interesting to see how they will then pan out in the next few months, years. There's been other approaches. For example, targeting the product of myelofibrosis clone, for example, the fibrosis. There are interesting data from Ruben Mesa team using a particular anti-reticulin that has been utilized in targeting some of the complications of the fibrosis. I haven't had a personal experience in this, and I'm not sure that it's actually open in the UK. So there are more data from United States, and it's a completely different approach, for myelofibrosis patients.